A very warm welcome. Delighted to be with you. For those of you I haven't met, my name's Maggie Rae, and I'm delighted that I have the chance to chair today's panel session. And of course, it's on my favourite topic in the world, health inequalities. So delighted we're having a focus on health inequalities, particularly in the Southwest, where I think lots of people come on their holidays and don't realise all the deprivation that we're facing and trying to help people with every day. So the way the session's going to run today is, I hope by this time you're all Slido aficionados, but if not, we'll be showing the Slido code again. I have 4 fabulous panelists. I'm really blown away. I've had a chance to meet them, and they've got fabulous things to say to us today. So thank you, panel members. They'll introduce themselves in a minute. And then my dear colleague, Sir Michael Marmont. Sir Michael and I are fabulous mates, and we worked together when I was leading on health inequalities at the Department of Health, in the only time we narrowed the gap in life expectancy and infant mortality. And my message is, if we've done it once, we can do it again. And I don't think we'll get a better policy paradigm than what's coming down the track now. So Michael, I mean, you know, Michael's a good age now, you know. He's very fit and healthy, walks everywhere, but he's traveling in Asia. He's gone to give the messages to the population in Asia about health inequalities, and boy, do they need it too. So he was really disappointed he couldn't be with us, but he has created a special little video for us. So shall we have a look at that first? Yes. Thank you.
Inequalities of health are the major issues confronting us. There've been a long-standing debate as to how to address them. People working in healthcare, of course, think that getting greater equity of access to healthcare is important. People in public health, people like me, think that the social determinants of health are more important. I had an interesting experience a few years ago. I was on a high-level panel in Stockholm, of all places, with 2 social scientists. And I, as a medical doctor, public health person, made up the third. And the 2 social scientists said the reason for improvement in health has been medical care. And I, as a medical doctor, said the reason for the improvement in health is improved social and economic conditions. I thought that was interesting. We passed like ships in the night. Well, we've got a new approach, which is not to fight this out, but to ask, what can the healthcare system do to address the social determinants of health? In other words, not say we've got to reduce child poverty or we've got to improve healthcare. We have to do both. And we can ask, what can the NHS, integrated care boards, the voluntary and community sector do to address social determinants of health? We've been working with the East London Foundation Trust that declared themselves the first Marmot Trust. And they've said they have responsibility for the health of the community they serve, not only the health care. So the first barrier we have to overcome is the conceptual one. Improving health for the population and reducing health inequalities is not only a matter of getting greater equity of access to health care, important as that is. The next challenge is, okay, we're convinced, but what do you want us to do? When I spent a year as president of the World Medical Association, I was trying to get the doctors to get serious about social determinants of health. And we produced a report and we said 5 things: education and training. Second, see the patient in broader perspective. Third, the NHS, the health service as employer. I would now go further and say the health service as anchor institution. I'll come back to that in just a moment. The fourth is working in partnership. And the fifth is advocacy. I said I come back to the health service as anchor institution. We did a report for business, the business of health equity, the Marmot Review for Industry. And we said that industry can be important in addressing health inequalities in 3 ways. Firstly, to be a good employer. Secondly, to look at the goods and services they deliver. Are they good for health or bad for health? And thirdly, to look at the wider impact on the community, purchasing, employment, environment, and the like. East London Foundation Trust took this report and said, we can do that. We need to be good employers, pay a real living wage, prospects for on-the-job training, career prospects. Second, we need to look at the quality of the services we deliver to the community we serve. And thirdly, to be an anchor institution, to look at pollution, employment, environmental impact, and the like. So there's a great deal that the healthcare system can do. After all, who cares about health and health inequalities more than those of us who work in the health system? Let me welcome you. Healthcare, the voluntary and community sector, the business, as our partners along with local government in improving health and delivering greater health equity.
So I'm just going to invite our panel members up, and Michael will be so pleased. I hope you all enjoyed that. He went to such a lot of effort to make it special for us. So that's fantastic. Thank you. So as I say, delighted we've got such a fantastic panel with us today. So if I could start with Huda, could you introduce yourself, please, and tell us a little bit about your organisation?
Thank you, Maggie, and thank you to the Health Innovation West of England for inviting me here. Can you all hear me okay? So my name is Huda Hajinur, and I'm the Chief Executive of Caafi Health. Caafi Health is a social enterprise organisation. We started about 4 years ago, and it was really, our work stemmed from the COVID pandemic, and when the NHS had this openness to work with communities to support community in terms of the vaccination outreach and to ensuring that people felt confident about taking the vaccine, and that's when we really started. And our organisation evolved from that. So we went from outreach, doing the vaccination and working in a unique way that I haven't experienced before in my career in the NHS, bringing communities together, bringing organisations together to work together for a really common goal. And that goal was to ensure people were having their vaccination. And the best way to do that was working with those people on the ground, and it was very much ground up. It wasn't top down, it was ground up, and it worked. The partnership worked, the communities were delighted, they were core front of this and had questions to ask, and the questions were answered. And so that's how we evolved. And from there onward, we're doing amazing work with community. I'm really proud of our organisation and how far we've come. One of our work we do is around research engagement, and we know that research has, for a long time, has not been well represented. We know that clinical research as well as normal research is not well represented. And one of the things that I think we want to do is to ensure that all research are represented, but beyond that, that we use the knowledge to mobilise it back to the community, that we talk to the communities around our findings. Often researchers are done, the findings are somewhere collecting dust, and it doesn't go through the community, so they don't learn, they don't take away. And I think the topic of when we talk about communities, and I'm talking about all communities across the board, is that there is a need, there is a hunger for them to have that information from us and us to deliver that information back to them. I think all of us here go, out to our work to ensure that we're doing the right things, and that's not, and I hear that all the time. Everybody wants to do the right thing, but the right thing is to centre the community in our conversation.
Couldn't agree more. And Simon.
Hi everybody, I'm Simon Allen, I'm Chief Exec of Age UK, Bath and North East Somerset. I've been in that role for the last 3 and a bit years, and I'm a social worker by background, and I've had a long and winding career which has included being a chair of a health and wellbeing board and working across the local government, NHS and mental health sectors. So I'm a jack of all trades. But really, in my role at Age UK, Bath and North East Somerset, I think one of the proudest achievements over the last few years has been similar to Huda's experience in terms of what's come out of the pandemic, and actually looking at how, as an organisation, we've been able to work alongside around 30 different organisations across Bath and North East Somerset, community and voluntary sector organisations, as well as the local authority, as well as our community health provider, to really join together and make things easier for people. Because I think very often, Sir Michael's talked about access to healthcare and access to services more generally. And I think that's really important, but we make it really complicated. We make it incredibly hard for people to access the support that they need, or to even find out about what they need. So what I hope to talk about later on is something that we've kind of has grown out of the pandemic, which is our community wellbeing hub in Bath and North East Somerset, and I'll speak later just about how we've managed to begin to do some of the culture change, particularly around those moments of big change for people, like hospital discharge, and how we can improve outcomes when it comes to that whole experience.
Fantastic, thank you, Simon. I'll pass over to Sean.
Hi, my name is Sean Hourigan. I am the Development and Training Manager for a project called the Peer Partnership, which is a project within a charity called Brigstowe, which has been supporting people living with HIV for the past 30 years. One of the most successful things that we did within HIV about 10 years ago was to implement peer support, where we took people who were experienced in living with health conditions and we let them provide the support for people who were newly diagnosed or struggling to deal with the condition that they were living with. Obviously with HIV, a lot of stigma, as well as the management of the condition itself. And it was so successful that a couple of years later, we wanted to see if this was something that could be adopted and spread into other long-term health conditions, and we created the Peer Partnership. The Peer Partnership takes all the lessons we've learnt in peer support and implements it into other long-term health conditions. We've done this for type 2 diabetes, long COVID, stroke, and we've got proposals for every long-term health condition you can possibly imagine right now. We're looking for partners with all of them. And we were running these services ourselves, but what we decided is if we want this to be more widespread, actually what we now do, rather than running services ourselves, is we go in and support other organisations to learn the skills of peer support and to implement it themselves. Not just in the VCSE sector, but our programmes are now running through NHS trusts, about 5 different NHS trusts across the country. So we've got programmes in London for long COVID, but we also moved beyond into things like students who identify as trans and non-binary, or ex-offenders in prisons, so who have left prison and need to reintegrate into the communities. And the whole point of why this is important for a situation where you're trying to deal with health inequalities is we're trying to remove the idea that people living with difficult circumstances should be passive recipients of care, but actually you can create people who are activated and engaged with their condition and can deal with the issues that are best dealt with in the community and remove that from the NHS and the burden that comes from having to deal with the sociological issues, when actually the NHS is set up to work around the biological determinants of health. People are best helped in their communities, and we are really keen on things like peer support, which is more analogue, which isn't digital, which isn't AI, that this is people in your community using the same services as you, having the same issues as you, and therefore best able to support each other in that way. And we believe that's a key aspect of supporting health inequalities.
Thank you. And Derek.
Hello, I'm Derek Tanner. I'm the Enterprise Development Manager at Black Southwest Network. When we describe what we do, we would call ourselves a racial justice organisation. Then I look at the question, and we're talking about health, we're talking about innovation. I mean, I agree with the video. Health is a kind of factor of a lot of social determinants, whether you feel comfortable in your place, whether you feel part of something, whether you've got economic ability to aspire to something or grow, whether you have the skills and knowledge, whether you have access to different things. And really, from my perspective, the organisation works in criminal justice, it works in culture and heritage. I lead enterprise. And that's really trying to stimulate economic growth and economic inclusion for disadvantaged, black and minoritised entrepreneurs, social entrepreneurs, and we have other part of our kind of economic strand, which is around charities as well. So when I'm looking at that and I'm looking at the question, we are looking at some structural challenges with small local organizations, local social enterprises trying to work with a very large organization and institute change. And how do you make that happen? So we've been delivering Health and Social Care Accelerator, because we've had 2 other pilot programs which were around incubation and around really breaking down that commissioning and procurement challenges, which create a market opportunity that enables investment, that enables growth, and enables wealth creation. So much of my work is around working with aspirational black and minoritized entrepreneurs and social entrepreneurs to engage with the systemic challenge of creating a market opportunity for themselves and then growing their businesses and developing their businesses. So that's really quite exciting work, because what I can say is there's talent and aspiration there. There's the potential to unlock that talent and aspiration to meet the needs of the challenges that we'll all probably be talking about, broken NHS system or how it engages with community more effectively. But I think when we come back to that question of innovation, that's around people being brave in having the strength to do something different to what has been done before. And in large organizations, that's really high risk strategy for a manager, right? And when it goes wrong, it's awful, right? And when it goes right, oh, that was clever, right? So again, my reaching out to you is just to kind of understand that there are different ways of doing things and to engage with that.
Thank you. That's great. So I'll kick off with the first question just to make life a little bit easier for you. And if you haven't managed to scan the code or get yourself on Slido, then we're hoping that we'll be able to get some of your questions to the panel as well. But I think what we're here today to acknowledge is doing nothing is not an option. We cannot control that people are born into poverty, and that's not their, that's not their choice. And look at the child poverty we have in our country, worse almost than it's ever been, except for Victorian times, probably. But we can do something about it. So Michael talked about how do we get serious about health inequalities. So I think, again, panel members, if you could think about from your own perspective, how would you suggest we get serious about improving people's life chances and their situations? Should we do it in the same order again?
Sure. Yes, thank you, Maggie. How do we get serious? Well, I think I touched upon it a little bit earlier, but to get serious about reducing health inequality or tackling health inequality, we really need to kind of centre around community and around listening and around co-production, not in a way that's tokenistic, and not in a way that's just consultation and going away, but in a way that we really need to put people first, listen to them, and create solution that works for those people. I think sometimes it's, in terms of innovation, preventative is not an easy thing that, you know, is looked at in the, and the outcome is not the same as the NHS standard, the matrix. You know, you cannot, there is no way of understanding the impact of trust. You know, it's difficult to put that into numbers in terms of outcome, but that's what people need. We need to develop confidence with our communities to build trust, and the only way we can do that is to go out to them and to work with them. Often I see innovations, people designing apps and everything else, and then, you know, communities that are going to use those services become an afterthought, and then you scratch your head and think, it's not having the desired effect. But the thing is, if we were to consult with those people to begin with, then we would have those desired effects. And I think that's where innovation goes wrong, is that we don't include the people that are using that services. And I think often everything seems to be a bit more, you know, great. We need to have the medical model, but we also need to have that community model where we are working with those people on the ground up, you know, to say to them, this is, people are asking, how do I look after myself, for example? You have many people who have so many other priorities that our priority that we set up from the NHS is not their priority. We need to align the priority. We need to listen and understand what is their priority. How do we support people? And if we do that, then we get healthier people. You know, it's good for our economic, it's good for growth. The services that we provide works, and it's as much as a business model as anything else, you know. So it's about centering everything we do around the people that are using our services. One of the things that I'm passionate about is talking to people. Despite, you know, I've only been around 4 years, I'm a person that the community can come to and tell what they want done. You know, they can, you know, I can, most of our innovation, most of our ideas come from the communities, because we sit there, we listen, we let people come to us and tell us what it is they want. How do we support you? How do we ensure that we break the cycle of poverty? One of the things we've done was that we were inundated with mothers, for example, from deprived communities who for a long time have raised children and were de-skilled and didn't know what to do but needed to get back to work. And we thought, well, why not create care workers so that we can help our ageing population? And that's a massive problem for us as a society, because if we don't have the workforce to support those people that are aging, we're not, you know, that's going to cost us economically. Right, so when we've done that, then we have so many people coming for work. So we're giving them that economic, we're giving them that skills, they're doing, and on top of that, we're talking to them around their health. So, you know, ensuring that they're looking after themselves, ensuring that their well-being is looked after, and then also listening to them as what we can feed back to the communities. So I think it goes back to the centre of why have we chosen to innovate, why have we chosen to be healthcare providers, why have we chosen to be a healthcare worker, and that's to make sure that the path that people go through is smooth for them, and to do that we need to kind of meet people where they are. We need to respect people's lived experience, we need to respect their realities, and we need to just back off a bit and take our assumptions away, you know, and listen to them. And, you know, if someone's re-attending A&E several times, we need to go and ask them, why are you doing this, and find out the reasons as to that. It's not a guess game. It really is around that advocacy, around that support, and not working in silos. You know, we know what happened, the lessons learned from COVID, and the way we all came together and worked really beautifully. But I think that was almost like a crisis driven. We don't know when the next pandemic is. Communities are tired. They're tired of coming to them when we need when there's a crisis and we need a solution very quickly, and then going away when there isn't a crisis. What happens when there is the next crisis? We don't know. We've got climate change. Yesterday I was told, due to the climate changes, there's diseases like dengue fever might be here. How do we then talk to people around vaccine again? If we don't continue to have those conversations, if we don't innovate from the community's perspective, if we don't include all of our communities, if we don't in particularly our ethnic minority communities, where we know, the shift in political drama that's happening, and people feeling really vulnerable at the moment and not coming forward with those solutions and those ideas, and really are scared to reach out to their healthcare. So I think we need to make that path a little bit more smoother for them.
Fantastic. Couldn't agree more. Well done.
So I suppose just following up on Huda's point, and I think it's amazing that Caafi Health have grown out of the pandemic over the last 4 years, because I think when I look back to that period of lockdown 1, communities themselves were the quickest to respond to the needs of each other in terms of neighbours helping neighbours. They were a fortnight ahead of everybody else. And actually what I suppose what I'd like to kind of talk about in terms of getting serious, I think we all got serious at the pandemic. It was an incredibly, certainly that first lockdown period felt like a real coming together of lots of different organisations, different types of people, different ways of working to focus on one pure thing, which was to keep our communities safe and well. And by way of an example, the Community Wellbeing Hub that I mentioned earlier, like every local authority area and every area across the country, there was that initial response to quickly identify people who were clinically extremely vulnerable, to be able to set up systems and processes to make sure that people had food, to make sure that people had their medication. And the Community Wellbeing Hub was the Bath and North East Somerset response to that. And worked incredibly well, to the point where, like lots of other areas, we had 2,000 volunteers, essentially one volunteer on every street across Bath and North East Somerset. And it got to the point then where you kind of ask yourself, as a collaboration of the local authority, our community health provider, and around 30 different voluntary and community sector organisations, how do we take this forward? How do we maintain this way of working, this collaboration? And I think sadly in lots of areas that some of that has kind of sprung back into old ways of working, and to be honest, it very nearly did that in Bath and North East Somerset, but we managed to keep that going over the following years, to the point where we're at now, where around a year and a half ago we set up the Community Wellbeing Hub at the RUH, so our local acute trust, and looking at how we could make it easier for people to connect to the sources of support in their community. So essentially, sources of support from our community health provider, HCRG Care Group, the local authority, and 30 different voluntary and community sector organisations who are providing 80 different sources of support and services. So essentially, the project of the RUH is in two parts. One is a visible presence in the atrium, so that people who are coming to visit a loved one, or maybe there for an outpatient's appointment, or a member of staff, could find out about what kind of support's available. And when I talk about the support, that's from support around money and income, through support from the CAB, right through carer support, employment support, a wide range of sources there. So making that accessible to people in the atrium was really important, and that for us was the real, true preventative part of the work. The second part was then, having experienced the pandemic and the retraction of support on the hospital in terms of, as part of that hospital discharge process, how could you make it as easy as possible for people to find out what was available, but equally for staff on the ward, how do you make it as easy as possible for them? Because ward staff, with the best will in the world, their focus is on people, hopefully, on the ward, not retaining the knowledge about what support is available in the community. So we worked with a digital partner who'd been there from the start, Rivium Digital Health, to create what is essentially a very quick and easy checklist for people to ask them questions about what they might need some support with when they get home. That checklist is completed with their consent, and instantaneously those referrals are then made to the partner organisations to then pick up. The crucial bit in all of this, and I think anybody working in hospital discharge will tell you this, that sometimes it can feel, if you're working on the ward, he says as an ex-hospital social worker, it can feel your options are very limited, and it might just be another bedded facility that somebody's going to, or home care that sadly all too often is in short supply. But for us, it was really important to be able to feed back when voluntary sector organisations like my own have been able to put support in place so that the ward can successfully and positively discharge somebody home safe in the knowledge that that support is going to be there when that person gets home. I'm really chuffed, to be honest, that the referrals going through that entire process now are as high now as they were at the start of the pandemic. And I think that's testament to the fact that there's been an awful lot of culture change on the ward to make use of it. And the fact that more people are finding out that actually there is a breadth of support available to them in the community. So hope that helps.
Well done. Thank you so much. Sean?
So mine's going to be a stream of consciousness because I didn't plan what I was going to say today. But I'm going to ask a quick question, and it's also following on from everything that's said, because I don't think you're going to find anyone on this panel who disagrees with each other. Who here knows what the term hard to reach? Can you raise your hands if you know what the term hard to reach community is? Can you keep your hand up if you consider yourself to be a hard to reach community? We have one. The term hard to reach community is incredibly victim blaming. Okay, the VCSE has realised this for quite a while, and actually we've tended to move towards a term underserved communities, meaning we are failing to reach them, not that they are hiding from us. So what we need to do is change people's thought process on this and make sure that what we recognise is that these people are ready to work with us as long as we give them opportunities to work with us, and that they can see themselves represented in the services that are being created, and that those services aren't a pilot project that lasts a year, which then gets cancelled. Then we get the NHS coming back to us saying, actually, we found the money now, can we restart it? And we go, well, no. Everyone involved has moved on, and they can't be bothered to start this whole process again. We see this time and time again. And what we also end up having a problem within the VCSE sector is we often get these tenders for services that the NHS is really interested in getting the VCSE sector to do. The programme's already written. They've already said what they want, how it's going to be measured, how it's going to be run. And we're now suddenly this round peg trying to fit into this square hole of what they want to achieve, rather than actually understanding that the VCSE is bloody good at what it does. We have extremely high skill sets in the work that we do because it's always reflective of the communities that we are trying to support. Instead of trying to get us to do something that you want us to do, tell us what you are trying to achieve and let us and the community design the programs that are going to work for them, because that is how you're going to get buy-in from the people who are the people you're trying to support. It's how you'll get VCSEs not struggling because we will try and grab the cash. We need it with the VCSE. We're poor. And we are often the poor partner when it comes to things like the integrated care system. As you're all aware, it's a partnership between healthcare, local authority and VCSE sector. Healthcare and the local authority have been working together for about 3 years now through the ICB. The Voluntary Sector Alliance has just been set up this year. I would suggest that's not necessarily a joint partnership and a partnership of equals. And I think we've often heard, sorry, you're going to get some bitterness here. You're going to have heard anyone who's been in the sector for as long as a lot of us have, where we have seen PCTs, CCGs, ICBs, who have all said, voluntary sector, you're now a partner. You're an equal partner with us. We can be a bit bitter, but we are also always hopeful, and we are engaging with the ICB process. But don't test us too much, because we are tired. We have exactly the same increases in the use of our services as you do. And we see people, we often see people when they've already been through social services, through healthcare services, they come to us and just like, well, what are you guys going to do? We often get them at their lowest. and we are the people who are then going to get them to engage with you again. But back to services. So co-production is what you need to do, and you need to recognise that the voluntary sector is better at being the lead partner when it comes to these kind of projects, because the communities already trust us. They don't always trust the NHS. I'm sorry, that's just the reality. That's what we hear from them, but we're the ones who get them to come back to you. Okay, and we can help them to engage as long as you make sure that the environment is safe for them, and the environment for us is that our reputations as VCSEs aren't damaged when services end or when services don't actually respond to what people are saying. So we are actually at the Peer Partnership, we do a lot of training and so on around trying to help professionals, both in the VCSE, health sector and everywhere else, to learn best practice in some of these areas. So we do workshops for how to run focus groups. We do workshops on group dynamics and facilitation. We do them on how to recognise and respond to challenging behaviour, because the VCSE deals with this on a daily basis. And actually, a lot of staff in the NHS get taught, obviously, the medical side of their work, but not necessarily on how to engage with the individuals that they're working with. And we are also now working, we're applying for a bid, so I can't say who it is with, but we are looking at developing action learning sets for co-production so that we can actually support organisations and NHS staff who want to do co-production but don't have the time or the capacity or the knowledge. We're working on that to see if that can be done. And we're looking at doing these action learning sets in a co-produced way as well. So co-production is the term that we all want to be listening more to, because it is how you are going to respond and actually engage those people who are not hard to reach, but currently are just underserved.
Thank you. And we'll hear now from Derek, and we'll try and fit in one question on Slido if we can.
Co-production, I think that's a common thing, a common thread. And if you can unlock the power of co-production, it's quite phenomenal. But then I look at that and I look at primary care, secondary care, integrated care. They don't sound the words of co-production to me. They sound more like siloed kind of, territory grabbing, and then, how do we negotiate from a managerial perspective, how money moves around that. I would say if you really want to deliver equality, you'd want to deliver inclusion, then where you need to start is by listening and actively engaging with the communities who are currently disadvantaged. Understanding your power to invest in those communities as the NHS, and in terms of the market opportunity, in terms of that you can create, in terms of your internal knowledge and skills where you can deploy them to help those organisations to grow or to engage with market opportunities, and to advance your understanding as leaders and managers within your organisation of the communities that you serve and represent. That is quite challenging, because as a large organisation, you have priorities, you have things that you have to focus on, you have teams to manage, you have God knows how many quotas or tick boxes to tick, And I would encourage a change of will, and that actually the innovation of reaching out and looking for opportunities to co-create and looking for opportunities to actually invest in organisations, whether they're in the VCSE sector or for-profits trying to kind of engage in activities that will stimulate wealth within their communities and skills within their communities. That presence and not distance will help you to build the trust within those communities, to build an understanding of the cultural differences within those communities, to build places or to engage those communities in places where they feel welcome, wanted, engaged with, and understood. Now, from my perspective, I'm working with 14 social enterprises who want to deliver services. And it's, like I say, it's a bit like a football club. When you look at the management level, there's not a huge amount of diversity. When you look at the people on the ground doing the actual thing, there's a lot of diversity. So for those people on the ground to want to build, not work for an agency or to go through some process where their skills are utilised in a way that's undervalued, underpriced, everything else, to actually look at the agencies they're working for and say, I'd like to create something like that, and we could do it better, we could do it more impactful, and we can deliver a better service than who I'm working for. For that to be stifled, that aspiration to be stifled by systemic, Ruby would agree, racism is quite damaging, right? So when I'm told, when I've got 14 aspiring organisations, that it will take 10 years for them to actually be able to engage with the NHS in an effective way to grow their businesses. And knowing that most black and minoritized enterprises, social and whatever, don't last more than like 12 months, 18 months, in reality, you're actually saying, forget it, go somewhere else. Or do your services under another label, go that way. Or to get through the commissioning process, you have to go off and do private work that demonstrates that you can do what you do, regardless of your nursing qualifications and everything else, right? Taking you away from your community and delivering another community so that you can demonstrate that you can it doesn't make any sense. And I think it's challenging, but what I can say is, I worked in the tech space for a period of time. I sat down with a guy over coffee, like we did it, and he said, oh, great ideas. Wait a minute. He got on the phone. He was in Lubyanka, got a programmer. That guy got somebody from Russia, blah, blah, blah. Within half an hour, we had a minimal viable product in the market. That is collaborative innovation. What is going on at the moment in terms of health innovation is a long way from that. If you really want a will to deliver change, deliver innovation, deliver the efficiencies, deliver the outputs in an effective way, you've got to look at your organization and say, how do we embrace that agility to look at a problem and present a kind of solution with all the innovation and all the other things that we've got available to us now than when my mother started as a nurse back in the 1950s, right? There are so much positive benefits from the NHS now. I don't believe it's broken. I believe there are opportunities for it to be brilliant, the best in the world. And I think in many respects it is the best in the world. So don't take that narrative. And it requires good leaders like yourselves to kind of embrace that.
Excellent, thank you.